Renee Hayden. I'm the CEO of the Australian Primary Mental Health Alliance, and it's very exciting to be here today. I've been working with Southwest Sydney probably from around October last year as a consultant, helping to remodel a couple of the programs, and two of them are being launched today, so it's really exciting. One is the Child Mental Health program, so the Staff for Kids program, which is great, and that's going to be launched a bit later on today. And today we're talking about the Credentialed Mental Health Nursing Service. So I'll be talking primarily around that today, and how this has come about. But it's a bit, we've just had a wonderful morning listening to Ian Hickey. My goodness, he brings out a lot of information, doesn't he, so quickly, and trying to write it down, but he's so excitable and he's got so much energy, and I just love it. I always come away feeling quite energised and knowing that everything is possible when I've heard him. And then I've just listened to a wonderful presentation by about the Only Human app. If you weren't fortunate enough to go into that presentation, if you do yourself a favour, go to their booth and download the app. It will be great for clinicians going forward with your clients, and it's just a beautiful app to support clinical intervention, so highly recommend it. So I'm feeling really buzzed at the moment. I don't have a smart app, and I'm not coming with a whole heap of theoretical academic knowledge, but I'm going to try and explain to you what the Credentialed Mental Health Nursing Service is about. So who am I? I'm Renee Hayden. My background is that I'm a credentialed mental health nurse, and I happened to fall upon work about 22 years ago with divisions of general practice. Oh goodness, with divisions of general practice as a credentialed mental health nurse, doing care coordination and support co-located in general practice. That was way before Better Access, way before the Credentialed Mental Health Nurse program started, and way before even ATAPS was even a thought. A lot of the work that was done with myself and a few other clinicians, both psychologists and mental health nurses, led the way for the development of better outcomes, which then ATAPS and Mental Health Nurse Incentive Program flowed out of, as well as Better Access. So I'm one of the dinosaurs that have been around for quite some time, hence the bright lights, a bit confusing. So where am I now? As a credentialed mental health nurse, I've worked in divisions, Medicare locals, PHNs. I'm now the CEO of a company that is led by mental health nurses purely by chance, and we have 185 mental health providers who have registered and aligned with us to assist them in navigating the system reform that is enveloping our profession, whether it be mental health, NDIS or primary care. So we have sort of we set ourselves up because we got a lot of questions, and that's sort of the beginnings of my company and what we're doing. Why am I here? Because Southwest Sydney engaged me as a consultant to do some of the remodelling on some of the programs. And so I've been spending quite a lot of time in the area working with mental health nurses and also working with services and doing some co-design to try and make sure that the future of the programs really address the population health need and equitability. Very soon I'll be introducing you to Amanda Butt. She's one of my employees, but also has now engaged with Southwest Sydney as a credentialed mental health nurse in the Liverpool area, and I'll talk a little bit more about Amanda. So, okay, I'm doing microphones and paperwork. So just to recap, and I know many of you have heard a lot about the mental health reform, but I'm wondering how many of you have actually read it? How many of you have actually read it? Yeah. And this is the government's response. So has anyone read that one? So going forward, if you're in the mental health space, if you're impacted in relation to Commonwealth programs, it's so important to know what is governing and moving and flexing in your area. This is the stuff of the future. This is what we all need to know. It's almost like having a crystal ball, knowing what to be ready for. So it's really important. If you haven't done it, I invite you to do it, because then you'll get a bit of an idea of where the government focus is. Now, we've just spoke from Ian Hickey about step mental health care and about various things that the government's wanting to do and putting more money in, and if the PHNs are working really well, then you'll get more money. If you're not working really well, you won't get it. But a lot of it is based on this reform. Mostly what it's around, the reform is around all the Commonwealth funded services. So that's ATAPs, that's Mental Health Nurse Incentive Program, that's Headspace's early psychosis, MISRA, that's the Mental Health Rural and Remote Services. There's a variety of national funded mental health services that this reform underpins. And it's really important that you understand it. It's about redistributing funding so it's commensurate to client need, so it sits along client need, and also that it's equitable and accessible. As we know with many things, like with ATAPs and mental health nursing, it hasn't necessarily fallen like that. There needs to be a better alignment with client need to what the services provide, rather than one size fits all. You're going to be fitting into 6 sessions. Oh, and you might get another 6 if you're lucky. You know, it's very different. They want it to be different. They're talking about recovery-orientated approach versus case management, specifically in the severe and persistent mental illness component where mental health nurses sit, which is what we're talking about in this room. Rather than it being the traditional care coordination and case management approach, the focus needs to change. Ian spoke about it time and time again this morning. Recovery-orientated practice is the thing of what we all need to focus on. The review talks about improved service coordination for care with for people with severe and persistent mental illness, and there needs to be clear links to the NDIS. Sorry. So when we talk about step mental health care, and whilst Ian was saying, you know, this could be the notion itself, step care, could actually could be problematic because people will need to go through steps to get to the top. That's actually not what's happening, playing out, so I'll challenge him on that one. What's actually playing out, and I work with a lot of PHNs, is you get assessed at the front end and then you get locked into the right step. You don't have to go through step A, B and C to get to D. So in truth, step mental health care just means you go to the right step to your need versus going up the steps to get to your need. Okay, so I just wanted to say that because I've not been working with one PHN that is doing the reverse, okay? So the key to that is why there's so many new central intake systems operating, why there's new documents being thrown out for the services to use, so that at the front end people can be matched and linked correctly. So for South West Sydney and for this region, for what we're talking about today, is the Credentialed Mental Health Nursing Service. And under the severe and persistent mental illness banner, it's at this last step. Okay, so we're talking about those with quite complex, chronic mental illness that is quite enduring and often struggle to be able to either access services or stay in services. For South West Sydney, that equates to roughly around 29,000 people, nearly 30,000 people. So in relation to the reform for mental health nurses, the key context that drove a lot of the changes was the fact that you may remember that the Minute program within 3 years of it opening was shut down. It was basically frozen. So it far exceeded the funding that had been set aside for it. The government's answer to that was, we're going to freeze you. So that meant that no new eligible organisations were able to be added unless one left. No new mental health nurses were allowed to be registered unless one left. And most people's books started to freeze because they were given a session cap. They couldn't do any more than what they had. I mean, you could have more people come in, but that just meant your caseload was getting bigger and you weren't able to put in new staff to support that. So things started to shut down almost, and it became a stagnated service, as almost like a blocked and locked in service, which made it, by that very notion, inaccessible, and it also stopped it from being able to grow. The other thing that was very interesting, some of the states were quicker than other states. Victoria went got nearly 65% of the mental health nurse funding, and the other states sort of dribbled little bits out. So it was very inequitable from state to state and from through the nation. The other thing too is from the notion when it was rolled out, the eligible organisations were traditionally owned by the GP. The GP or the practice were the eligible organisation who then the mental health nurses were able to be contracted under. So there were PHNs or Medicare locals or divisions of general practice, Medicare locals, PHNs who had engaged mental health nurses also, but many were connected in through eligible organisations. In some of those eligible organisations, and most of those eligible organisations, the GPs in that practice locked that nurse down to that practice. That didn't happen for everybody, but for many. So therefore it became even more locked down. You're seeing, unfortunately, because of the way the initiative was rolled out, these were the ripple effects. It led to quite isolated practice for the nurses, so they weren't able to bring on more peers to support them. There was little ability to refer across initiatives, and there was inconsistent governance and oversight. So some practice, there was quite clear governance, and we knew it was happening. In other areas, there was huge throughput, and there was variety in the way that the program was rolled out. Okay, So Southwest Sydney's challenge was they had still only had limited funding. They had a small amount of mental health nurses currently delivering services, and you'll see shortly what the footprint was. And the need was to make it equitable, the need was to make sure it aligns with the step mental health model, and the need was to ensure that the referrals were able to come from a broader footprint but still have the clinical backup and assessment that needed to happen for the complexity of the group that we're talking about. So the methodology behind the remodelling of the MINIP program was our company meeting with the PHN and having a bit of making sure that we were clear about what needed to happen, analysing other models, doing a sector scan and doing a literature review, and then doing lots of consultations. We did lots of consultations with GPs, with psychiatrists, with public psychiatric services, with private psychiatric services, and also with clients, and mental health nurses, sorry. We then developed a sort of a service delivery framework that we then started underpinning how we would write the model. And part of that was around, I'll go into it in the next slide, sorry. So, and then we were looking at how we can develop a workforce support strategy to continue to recruit more nurses to the environment, and look at how we can transition current clients into the new steps that were about to take shape. We also wanted to develop some sector awareness sessions so we can start to train or inform general practice and primary care on referral pathways and how to refer appropriately. So we did a significant literature review. We did 4 co-design sessions, and we did consultations face-to-face and via telco. So this is the footprint of what it looked like. So Southwest Sydney took on the role of governing or with the auspice agency for the credentialed mental health nurses, the MINIP program, when the PHNs came on board from 1st July last year. So as you can see, in the orange dots, that's where the mental health nurses were. And the blue dot is an independent mental health nurse that's being funded philanthropically in another entity. The yellow are the identified gaps, where there isn't a footprint and where there's just as much need. Yeah, so you can see the dilemma that's happening. So we did significant consultations, as I said, and the key thing was around ensuring, we kept talking about equitable access and availability. How are we going to make this open and available, knowing that we still only have the capacity to have 5 to 6 mental health nurses. So, 30,000 people, that's the need, big geography, 5 to 6 mental health nurses can only be funded. So how can you best utilise that workforce without burning them out and without setting up a program that's not going to work because you can't meet the demand? All right, so that was our dilemma. How are we going to support the workforce to redistribute themselves and make sure that their businesses are viable in doing that? We were looking at service delivery and what kind of service delivery options are best, co-location, home visits, looking at us co-locating with headspaces or GPs. If we co-locate with a headspace, can adult clients go in there? What are the dilemmas that we've got and what is available to us? Pardon me. And also looking at capacity building. One of the things that certainly kept coming out was just because you became a credentialed mental health nurse through the College of Mental Health Nursing doesn't mean that you were skilled in working in primary care. Primary care and tertiary care is very different, very, very different. And you really need to understand how primary care works. You need to understand MBS, you need to understand engaging general practice, you need to understand a significant amount of things. It's a very different environment. You also need to understand and be confident in working autonomously with very little backup. So how do you do that? So we wanted to make sure that we can build the capacity of our mental health nurses and support them as best we can. There was also the capacity building around practice nurses. One of the big things that kept coming out was practice nurses have regular touch points with clients with mental illness. That can be when they're doing a dressing, it can be when they're doing a physical health check, it can be doing when they're just speaking to somebody. And they have the opportunity to have a conversation with people. So how can we skill them up to be able to do that confidently and then know how to connect someone to the right path? So that was another process that we were looking at. The other thing was, how do we transition new mental health nurses into primary care? How do we support them? And then doing some sector awareness sessions, as I said. We also wanted to have some clear pathways to care because we didn't want to set up a wrong door environment. We wanted to continue to embody the no wrong door concept. So this is what we wanted to achieve and this is what we were remodelling into. So we spent a lot of time with mental health nurses talking about where their preferences might be, what would they need to support a transition to a new environment, what would they need to support their clients because they would have to move some clients aside to be able to move into a new area. Do all their clients on their books currently need to be on their books? How do we support them in transitioning low-level care clients to alternate pathways now that the STEP model is now coming into fruition, etc. We needed to, it's fine to say to the mental health nurses, okay, everyone redistribute, but they've got a current client load that they've had for quite some time and they needed the time to be able to transition clients and support clients and make sure that they're, do warm handovers and make sure they're totally engaged. But this is where the footprint that we needed to move to. 2 credentialed mental health nurses came on, new nurses, and so we were able to support them in coming on board. So very quickly, now I'm running out of time. 5 minutes. Okay, I need a man to talk. So with the new model, basically we changed the name. We looked at different funding formulas, so the nurses are paid very differently. They have a unit versus a session. A session was 3.5 hours. They're now paid per unit, which is 60 minutes. The units can be split and be more amenable to what clients need. We've co-located some of the mental health nurses strategically with NGOs so that to maximise referrals and also create that collaborative approach. And we've just started to promote the services now that everyone's settling into their new roles. So I'm going to move to, we'll have these slides up later, but I'm just really conscious of that I've running out of time. I'm going to move to what does a credentialed mental health nurse do, because I think that's really important. I'm going to invite Amanda, introduce you to Amanda. Amanda's new, so Amanda's one of the transitioning nurses who's been supported into a new role. So it's very exciting for her to be able to talk about what she does and what that looks like for her. So,
thanks so much, Renee. So when you all came in, you would have received one of these. Has all the information there, just in case I do run out of time. It's all in there. So what does a credentialed mental health nurse do? So we provide a therapeutic alliance with the client. We close liaison and support for family and carers, comprehensive mental health assessments, monitoring of mental states every time we see the client, collaboration, networking, that would be with GPs, multidisciplinary teams, anyone who's involved with the care, contributing to the care of planning, psychoeducation, therapeutic interventions if trained, so CBT, motivational interviewing, all those sorts of things. Just go to the next slide. So the eligibility, so the big thing, they need to be diagnosed with a mental health disorder either by ICD-10 or DSM-5, or exhibiting significant symptomology of a mental health issue, so they don't really need to be diagnosed. The disorder is causing significant disablement to all personal aspects of their life, their schooling, their work, all those sorts of things. They've experienced at least one hospitalisation in the history of their mental health issue, or they're at risk of hospitalisation if we don't do something quite immediately. The treating GP or the psychiatrist will be the main person contactable with regard to care, so there will be a partnership between the credentialed mental health nurse and the GP or the psychiatrist. They will be expected to continue treatment for the next 2 years, so it's a long-term thing. And I think the most important thing about this is that it provides unlimited sessions to the client. They're not bound by the 6 or the 10 or the review or the 12. It's unlimited sessions, so depending on how much they need, they can see me twice a week, 3 times a week, and it's very, very flexible. So during times when someone's experiencing a crisis, they'll be able to get that care that they need. And then when they're doing well, it could be monthly or so. How to refer, they go through the intake line through the PHN, or they can come through the credentialed mental health nurse. There will be someone to determine the eligibility, making sure they meet the criteria. They will eventually need a GP mental health care plan, and it is a self-referral. It's a self-referral pathway, so the client feels like they might need some care or something like that, and they are aware of the service, then they can self-refer. The social worker can refer, the family doctor can refer, the community mental health team. So it can come from anywhere, and then either the intake line or myself will determine eligibility. And that's it, I think.
Sorry, you've got a minute.
A minute, okay. So there's a referral form that they'll need to complete, and that's just to get all the demographics and the details in there. There is no age limit, but for myself I see 12 up to elderly. It's quite flexible and broad, phone consultations, home visits, in sessions, just a very, very flexible service. So very grateful for what the PHN have put forward. That's about it. Is there anything else that we need to add? That's it. Okay. So yeah, you've got these, make sure you look through them. Eligibility is quite clear in there. And if you have a client in mind that you wanted to refer, just come see me afterwards. Thank you.
She's very new, so it's great. it's great to be able to introduce one of the new nurses in the area. So this is the catchment now. These are the guys that are there, and we can certainly provide more information. But primarily, rather than remembering numbers or names, they are well spread across the LGAs, and so you can ring the referral line and then be asked to be linked through. Remembering this is for people with severe and persistent mental illness, so and with a diagnosis or not, but has significant symptomatology that's enduring and long term. The mental health nurses can work in a variety of different ways, and the unique thing is often people will do home visits if the environment is safe and there's clinical support. So the mental health nurses work collegially with general practice and psychiatrists and the referral person, and also with carers as well. And mental health nurses will also be able to help with medication sorting out. They know their medications very well as well. That's really it.